Good afternoon, everyone. My name is Kathy Ottenhoff, and I'm one of the Born coordinators. On behalf of Born Ontario, I'd like to welcome you to the Born Provincial Rounds to ask or not to ask the implications in capturing valid alcohol exposure data for fetal alcohol spectrum disorder, FASD, diagnosis in later childhood. A question and answer period will occur at the end of the presentation. Please type your question into the chat box in the lower left-hand corner of your screen. Feel free to enter a question at any time during the presentation. As you have heard, these rounds are being recorded and will be posted to the Born Ontario website. We're very pleased to have Kelly Oreskowicz and Erica Henry presenting today. They're both located in Sudbury and are with Glenda Hicks, one of the Born coordinators in the province. Kelly originally trained as a registered midwife working in emergency medicine in the Northwest Territories, and she then completed a master's in social work from Laurentian University. Kelly has worked in a variety of settings, including hospital, community, and the private sector. Kelly returned to the hospital setting 2 years ago, where she coordinates a multidisciplinary diagnostic clinic for FASD at Health Sciences North, NeoKids. She is a staunch advocate for children who have been exposed to alcohol prenatally by facilitating the diagnostic process. Erica is a fourth-year BSW student at Laurentian University, completing a fourth-year placement with the FASD Diagnostic Clinic. She has a child and youth worker diploma and hopes to pursue a career in clinical social work in pediatric mental health setting. So a very warm welcome to Kelly and Erica, and I will begin the presentation. So the objectives today are to describe the Born Information System, or BIS, data definition of alcohol exposure in pregnancy, review provincial BIS data for 12-14, outline barriers that affect data quality and care, and describe how to review your BIS data on alcohol exposure in pregnancy. The Born Information System data definition of alcohol exposure in pregnancy is the self-reported alcohol consumption during pregnancy. And we have a standardized serving list and a single select pick list value, so we've provided further instructions in our definition on how to choose those accurately. You can see the pick list values in the box on the left, and a note there that says the data elements of episodic, excessive drinking or binging, and exposure prior to pregnancy confirmed amount unknown were both pick list values added in April 2014 as part of the BIS enhancements. This is a screenshot of the pregnancy tab where the alcohol exposure and pregnancy data element can be found in the BIS. So this data element is found in the antenatal specialty, antenatal general, labor, and birth mother encounters. So why collect this data? The SOGC Alcohol Use and Pregnancy Clinical Guidelines notes that alcohol is a recognized teratogen. Alcohol can negatively affect maternal and child health, and children with FASD have lower health and quality of life outcomes. And we'll be learning a lot more about these issues today from our expert, Kelly. The other reason to collect this is that Born data can be used to develop policies, programs, initiatives, and research to improve care of women and children who are at risk for FASD. As most of you know, Born recently released its annual report, and this report presents maternal newborn data for births of Ontario women that occurred primarily in the fiscal years 12-13 and 13-14, including alcohol consumption in pregnancy. This is data from that report. So the proportion of women in Ontario who reported consuming alcohol while pregnant was 1.8% in 12-13 and 13-14 combined. And of these women, almost half, 45.6%, reported having less than 1 drink per month. So in all likelihood, this is underreported in the biz, and we know from referenced publications that it should be higher, with some publications reporting alcohol and pregnancy use as high as 30%. So of the small but important number of women who reported consuming alcohol during pregnancy in the biz, we can see here the distribution of the amount of alcohol they reported consuming. And as mentioned, the majority reporting less than 1 drink per month at 45.6%. Of note is the high percentage of records that were excluded for missing data. So 26.7% of records were excluded for missing data. And we'll touch on that in a moment. Screening for alcohol use. So according to the SOGC Universal Screening Guidelines for Alcohol Consumption, screening should be done periodically for all pregnant women and women of childbearing age. And it's the responsibility of the healthcare team to ask early to reduce exposure by helping the woman seek help for her addiction. Throughout pregnancy, as any exposure at any time can cause harm, and then again when she presents in labor. And documentation is critical to ensure important risk factors such as alcohol exposure in pregnancy are documented not only in the woman's chart, but in the newborn's chart, and that chart is available and that information is available to the healthcare provider caring for the baby. So barriers to getting complete and reliable data on alcohol exposure can affect not only the care of the woman and her child, but be a barrier to developing initiatives and supporting research to improve care of these women and their children who are at risk for FASD. So some of the barriers include not screening. If you don't ask the question, you're not going to get the answer. We saw high levels of missing data on alcohol exposure in pregnancy within the biz at 26.7%. And missing data is unknown data. So that's where the user has entered alcohol exposure in pregnancy to be unknown. So why is it unknown? She wasn't asked, she was asked, and nobody recorded it in the antenatal record, or nobody asked her in the labor and delivery department, and it wasn't recorded in her chart, and obviously wasn't recorded in the biz. Another barrier is not providing a safe environment for women to report alcohol consumption, where there's shame and blame instead of feeling comfortable and supported. And we're going to hear a lot more about these things from Kelly. There's also fear of child apprehension and discrimination and feeling a lack of support from those in the healthcare profession that can assist these women with their alcohol problem. And it all goes back again to providing that safe environment. So another barrier is limited documentation on alcohol use in the maternal and newborn records. And as mentioned, the need to document is crucial for providing care and for collecting accurate and complete data. So how can we overcome some of these barriers? Well, we can work with the providers in our area to ensure screening throughout pregnancy. We can screen each time the woman comes to the hospital, including labor. Ensure women feel safe in reporting, document patient response on the maternal, newborn, child, and health records, and of course in the biz, and decrease missing data in the biz by limiting the pick of unknown. So reinforce the need to capture this important data element with those that enter the data. So we need to take time to search the patient record for the data. We need to take the time to ask the mother and ask in the right environment. And we need to take the time to enter it accurately, both in the chart and both in the biz. So Healthy Babies, Healthy Children, or HBHC, is a provincial program under the Ministry of Child and Youth Services, MCYS, that helps to support vulnerable women, children, and their families. The HBHC screen is a comprehensive tool that identifies these families. So currently, there is a pilot project underway that sees HBHC screening tool housed within the biz, and it allows some of the data collected in the biz to pre-populate into this HBHC screening form, including alcohol exposure in pregnancy. So you can see why collecting alcohol exposure in pregnancy data in the biz accurately is so important to patient care. So we're able to evaluate risk and allow the family to receive the appropriate support and services they need. So this is a screenshot of a portion of the BIS HbHC screening form that pertains to maternal alcohol use. So you can see question 10 says maternal alcohol use during pregnancy, and it's been pre-populated to yes. And then there's instructions within that form to the person doing the screening on why that's important. So alcohol exposure in pregnancy, we'll just have a look at the BIS data review and how you can use the Key Indicator Report Maternal Summary to look at your data. So as mentioned, alcohol exposure is available to all hospitals through a Key Indicator Report. And to access this report, you'd go to Reporting, the red circle on the top of the page here, then the Clinical Reports tab, the bottom circle, and then you're going to click on the Key Indicator Maternal Summary. Accessing this data is as simple as entering the start and the end date for the period of time you wish to look at your data, selecting alcohol exposure from the drop-down menu, choosing your organization, and then clicking View Report. So once you've done that, you'll see this report. So this is mock data. You can see the total number of women who have given birth broken down by alcohol exposure in pregnancy. And if you need any help accessing this report or any of the other reports or data elements that you're looking for in the BIS, just contact your board coordinator and we're always happy to help you. So really easy to have a look at this data. So once you pull the data and once you've had a look at it, what do you do with it? Well, the best thing to do is share it with your team so you can work collaboratively to review the data and decide where improvements can be made. So this will enable you to improve your care for this population of women and children. So now I'm going to turn the presentation over to Kelly and Erica.
Thank you, Kathy, and we'd like to thank Bourne for inviting us to speak today. Today we're going to talk about FASD and prenatal alcohol exposure. We're going to discuss how alcohol affects the developing fetus, and we're going to share some information about FASD, specifically the primary and secondary characteristics, as well as a little bit of information about the new Canadian diagnostic guidelines just emerging in the next month or so. We will frame the problem, which is access to data confirming alcohol exposure, and then describe how this impacts FASD diagnosis and the FASD-affected individual. And lastly, we'll review a few methods of inquiry to help health practitioners feel more comfortable in asking about alcohol use. First, I'm going to pass the virtual podium over to Erica Henry, who has prepared some myths and facts about FASD.
Hi, everyone. So just bear with me for a minute while I get the Prezi up and going. If anybody else has ever used Prezi, it can be frustrating at times, so just give me a minute. Okay, there we go. Okay, so I'm going to play a little type of game with you guys, and it's Mythbusters, and we're going to bust some myths surrounding FASD and women drinking during pregnancy. So our first myth is that women know they are pregnant immediately. As many of us know, this is not true, and approximately 50% of all pregnancies are unplanned. Many women do not know they are pregnant until their 6th week of gestation. Okay, so our next myth is that only women who struggle with an alcohol addiction give birth to babies who have FASD. This is definitely not true, and in fact, 75% of all women drink alcohol, And many of you may be surprised to learn that those who are at the highest risk of giving birth to children with FASD are Caucasian, over the age of 30, have a post-secondary education, are unmarried, have steady employment, and earn an annual income of over $50,000. So a commonly spread myth is that 1 or 2 drinks during pregnancy are harmless. This is not true, and there is no safe amount that a woman can drink during pregnancy. Our next myth is that fetal alcohol spectrum disorder is readily apparent from a person's looks. This is also not true, and less than 5% of people who have FASD show actual facial features. There is only a short period during pregnancy when alcohol use can affect these features, and research has shown us that as children enter puberty and grow into adulthood, these facial features can in fact fade. This is why the disorders under the FASD umbrella are often referred to as invisible disabilities. So our next myth is that FASD affects children and adolescents and adults don't have it. This is also a myth, and permanent lifelong disability is something that FASD is, and adults definitely face greater challenges because as they age, their behavior becomes less and less acceptable, and they also face a number of secondary disabilities that Kelly will touch on later. Many believe that their behavior is just a choice and that people with FASD just need to try harder. This isn't only a myth with FASD, but with many mental health disorders as well, especially when looking at children. In fact, the brain damage associated with FASD makes it difficult and for some even impossible for them to control their behavior. Their behavior is not a choice, it's just the way that they are. And our final myth of the day is that a father's alcohol consumption prior to conception can cause FASD. This has been known not to be true, but men and fathers can definitely play a key role in the education and prevention of FASD. And that was Mythbusters.
Okay, thank you, Erica. And that was a bit of a technological feat for myself, but Erica is very adept. So thank you again. So what is a teratogen? A teratogen is any agent that can disturb the development of an embryo or a fetus. For those of us who remember the 60s, you may recall the devastating physical deformities caused by thalidomide, a drug used to treat morning sickness in pregnant women. Thalidomide is a teratogen. Alcohol, too, is a teratogen, and while alcohol exposure can cause physical impairment such as organ malformation, the most catastrophic effects are to brain development, physically at a structural level and chemically. Damage from alcohol exposure can happen at any time during the pregnancy, and the severity of impairment seen are associated with the timing and the level of alcohol exposure. The degree of impairment is not necessarily related to one area of CNS impairment, but how that area of the brain interacts with other areas of the brain. The fetal brain is always vulnerable to damage from alcohol exposure, as is the adult brain. On this slide, you see some imaging of the brain. On the left is a normal brain, and on the right you can see the effects of alcohol on brain structure. This is another image of actual brains. Once again, on the left is an image of a normal brain, while the image on the right is that of a brain exposed to alcohol prenatally. Keep in mind that this is a very severe example. Note the smaller size, the structural abnormalities, and the grossly decreased surface area, or a lack of gyrification due to less cortical folding. So these two previous examples are quite dramatic, when in fact clinical imaging shows abnormalities to structure in only about 15% of cases. Most of the damage is at the microscopic level. When we look at these slides, you will note the organization at a cellular level. In the normal brain, it is quite organized, and the disorganization of the alcohol-exposed brain on the right. This disorganization has also been seen in PET scans. When individuals with and without FASD performed the same task, there was considerable difference in imaging. The neurotypical brain showed activity in one specific area, where the alcohol-exposed brain showed numerous locations of activity. So we know that alcohol exposure can affect any part of the brain depending on the timing and level of exposure. So what we see in FASD-affected individuals varies immensely. On the right are some examples of domains that can be affected and how someone with FASD may present. In our clinic, we see children with motor, coordination, balance problems, problems with attention, speech delays, problems with cognition, memory, and higher-order reasoning or executive functions. They may also have impaired adaptive living skills and may be unable to live without assistance. So, FASD is a group of effects that occur when a mother drinks alcohol during pregnancy. Depending on which researcher you're listening to, it's present in 1 to 5% of the population. And in populations where there are higher rates of alcoholism, the prevalence may be considerably more. Alcohol is the leading cause of developmental disability worldwide. Alcohol is in fact diffuse organic brain damage that causes congenital anomalies in addition to brain anomalies, such as organ malformation. FASD is unpredictable in its developmental outcomes. It's a spectrum disorder, depending on how much alcohol one is exposed to. Children and adults with FASD may need considerable support, and some adults actually hold down jobs and are able to live independently. FASD is not curable and is a lifelong disability. And when we describe FASD, we describe it as having primary and secondary disabilities. For the most part, however, FASD is preventable. Primary disabilities are present at birth and are a direct result of alcohol exposure. They reflect permanent differences in brain structure and function. While children with FASD may have a number of facial features that can be considered atypical, there are 3 distinct features that set FASD apart from other disorders or syndromes. These features are small eye slits, a thinning of the upper lip, and a flattened philtrum, or that vertical groove between the nose and the upper lip. Decades ago, the facial features of FASD received a lot of attention. But the presence or absence of these facial features depends on whether alcohol was consumed in a very narrow window of time during pregnancy, sometime during the 3rd week of gestation. It does not reflect the degree of a brain disorder, and the vast majority of people with FASD do not look visibly different. And with the onset of puberty, as with what Erica has already reviewed, the face also undergoes changes, so the best time to diagnose facial features is in early childhood. Primary disabilities also include central nervous system and cognitive impairments that will be reflected in that individual's ability to learn, manage their emotions, and manage their behaviors according to social norms or our expectations of them. And these children are often identified with attention, behavior, and learning problems within the school setting long before they're diagnosed with FASD. Affect regulation, which includes DSM-5 diagnoses under anxiety and unipolar depression, as well as the childhood disorder of disruptive mood dysregulation disorder, is a new addition to the diagnostic guidelines. As FASD is more widely researched and understood, It's understood not only to cause abnormal brain structure, but abnormal brain neurochemistry as well. Affect regulation is a welcome addition to the diagnostic guidelines, and I believe it will improve the diagnostic process. Children with FASD may also be small. However, with the new release of the guidelines, growth restriction has been taken out of the diagnostic criteria. As with facial features, growth restriction is not as prevalent as once thought. Secondary disabilities are described as arising from the primary disabilities. Individuals with FASD are not born with these problems, but as they interact with systems such as the school system or in the community, and they are not well understood, when expectations of them are not consistent with their abilities, they may experience a host of problems. They may experience mental health problems, disrupted school experience. Many adolescents and adults with FASD come in contact with the law and may be incarcerated. They may demonstrate inappropriate sexual behaviors, and many are vulnerable to alcohol and drug problems themselves. FASD individuals may need others to help them live and often experience employment problems. The extent to which any individual may experience a secondary disability commonly seen in FASD depends on the degree of support that they've been provided. This makes the case for early diagnosis and intervention, which are crucial to reducing the extent and severity of secondary disabilities. So why get a diagnosis? This is a question commonly considered by families as they feel a diagnosis of FASD may stigmatize the child or the child and family. Since no two children with FASD will present with the same constellation of impairments, diagnosis is beneficial, well, actually crucial, to understand the child's specific needs and strengths so that interventions can be specifically tailored to that child. We also know that early diagnosis and intervention is a best protective factor leading to better outcomes and fewer secondary disabilities. Diagnosis helps those working with the child to manage their expectations of that child and to make adjustments in their environment. For older children and adolescents, diagnosis helps them understand themselves better so that they can seek their own supports and advocate for their needs. Since the risk of having an FAS child increases with parity, diagnosis of one child with FASD may help that mother access supports and treatment so that she reduces the risk of having another child with FASD. I want to quickly review the new diagnostic criteria set to be published online in mid-December. For those of you that may know the 2005 guidelines, there are a few important changes. The first is a change to nomenclature. FASD used to be an umbrella term and not a diagnostic term. Without going into specifics and reviewing old versus new terms, for simplicity's sake, FASD is now a diagnostic term. We have FASD with sentinel facial features and FASD without sentinel facial features. So let's start here. To receive a diagnosis of FASD with sentinel facial features, you must, of course, have all three features, as well as 3 areas of central nervous system impairment, which I'll review in a moment. There may or may not be confirmed alcohol exposure, as the presence of all 3 features indicates alcohol exposure. But keep in mind that this is the minority of cases by far, less than 5%. To receive a diagnosis of FASD without sentinel facial features, you must have confirmed alcohol exposure, as well as 3 areas of CNS impairment. To the far right, you'll also see an at-risk category. This is a designation and not a diagnosis. It helps us monitor those who may not be able to complete all the testing necessary for a full diagnosis, such as a very young child. A child identified as at risk is to receive support and intervention, as would a child diagnosed with FASD, until a full assessment can be completed. As you can see, before assessment can be undertaken for FASD, alcohol exposure must be confirmed in the vast majority of cases. Without it, a diagnosis cannot be made. The largest barrier to diagnosis is the absence of confirmed prenatal alcohol exposure. So from an FASD diagnostic perspective, there's seldom detailed information found about prenatal alcohol exposure. The biological mother may be deceased. The child may be adopted or in foster care. There may be a poverty of documentation in the medical or child protection record. Privacy considerations prevent access often to the maternal record. Just in our hospital, from an anecdotal perspective, as recently as 2008, labor and delivery room charting did not include a prompt to ask about alcohol use, but it did include prompts to ask about smoking and other drug use, neither of which cause the devastating effects of alcohol. So review of the child's birth record often yields little information about prenatal alcohol exposure when there is exposure. So often there is strong suspicion in the documentation that we read, but it just falls short of confirming prenatal alcohol exposure. FASD assessment is conducted by a multidisciplinary team. In our clinic, our team includes a social worker, a pediatrician, nurse, psychologist, occupational therapist, and speech and language pathologist. On this side to the left, you will see a list of CNS domains as reorganized in the new diagnostic guidelines. At our clinic, we test all of these domains. An individual must have 3 domains of impairment at or below the 2nd percentile to receive a diagnosis. The assessment process is lengthy. In our clinic, we span it over 3 days. Despite discussion about thresholds at which neurobehavioral effects can be seen, the message that needs to be made is that there's no safe amount of alcohol. Women who are trying to get pregnant or who are pregnant are advised to abstain. The threshold for unsafe exposure is shockingly low and defined as 7 standard drinks in a week or 2 binge episodes throughout a pregnancy, a binge episode being defined as 4 drinks in one sitting. As we learned earlier, it is not true that FASD-affected children are born only to alcoholic mothers. When we look at the thresholds, we can see a lot of drinking habits and patterns that fall short of alcohol dependence that would exceed the threshold and place the fetus at risk of harm. For example, the binge drinking patterns of college and university students, or the young affluent professional who's accustomed to a glass of wine at dinner time. Of course, binge episodes increase the risk of teratogenic exposure due to peak blood levels. In the world of FASD diagnosis, we cannot proceed with assessment or make a diagnosis of FASD when we cannot confirm prenatal alcohol exposures. One of the solutions then would be more consistent capture and recording of alcohol use. So why is there such a gap in in information collection? A survey of health professionals gave us some clues. Some health professionals said they feel uncomfortable about asking about alcohol use. They cite concern about embarrassing or offending women who do not use alcohol. Others stated they lacked knowledge of alcohol treatment and counseling service, or that there was a lack of these services in their practice area. Yet others stated they did not ask because they were pressed for time. Interestingly, in a survey of obstetricians, only 49% discussed the dangers of alcohol, while 89% discussed the dangers of smoking. This data may speak to the need for education of primary health care practitioners as well as specialists in reproductive care. So why ask about alcohol use? Well, because the Canadian Guidelines for Diagnosis of FASD recommends that we do. It recommends screening for all pregnant and postpartum women, as well as periodic screening of all women of childbearing age. We should ask to normalize the question, and we should ask well before the age of conception, once again to normalize the question. We should ask early in pregnancy to allow for early intervention and supports for women who do have problem drinking. And we should ask again postpartum to help that woman maintain or initiate change if she hasn't already done so. We ask so that we can identify alcohol-exposed infants early. And, of course, for the purpose of this presentation, we ask so that prenatal alcohol exposure can be confirmed for the purpose of FASD assessment and diagnosis. When to ask. Some researchers and primary care practitioners in the field of FASD suggest that children as young as 10, boys and girls, be asked about their alcohol use at every health practitioner visit. This helps normalize the question. Certainly, men and women of childbearing age should be asked, as well as those planning a pregnancy or who are pregnant. Once pregnant, it's recommended to ask at every visit. Ask early, ask often. If a woman has consumed alcohol or has problem drinking, asking the question provides opportunity for education and early intervention. The Canadian Alcohol Use and Pregnancy Consensus Clinical Guidelines recommend 3 levels of screening. The first level is at regular health exams. The second level occurs once drinking is identified, and patients are screened with standardized measures such as the tweak or the taste. When problem drinking is identified, when there are child protection concerns or medical complications, a third level of inquiry may include laboratory-based screening tools. For the purpose of this presentation, we're going to focus on the first method of inquiry at regular health exams. When discussing alcohol use, it's crucial to create an environment of acceptance and compassion. Often women drink before they know they are pregnant, or because they do have problems with addictions, mental health problems, past trauma, or all of the above. Their guilt and shame may be significant and will be a barrier to a disclosure. Take time to build rapport and put her at ease. One or two interview questions have been found effective to screen, identifying women who are drinking and who are in need of education or intervention. The single question method helps open the door not only for women, but for health professionals who may not yet be comfortable in asking questions about alcohol use. There's a few examples of questions up on the screen. There should never be a missed opportunity for education. If a woman cannot disclose her drinking, she may be able to affect her own change once she is aware of the dangers of drinking during pregnancy. If a woman cannot disclose alcohol use at first contact, she may be able to at subsequent contacts, allowing for intervention and treatment. Motivational interviewing is a learned skill and can be effective even with short patient interactions. In collaboration with a health professional, a woman can come to identify her own motivation for change and act on it. The motivation for a healthier baby is a powerful goal, but keep in mind that women with problem drinking may need significant supports to reduce harm or stop their alcohol use. When opening the door to intervention, be prepared to have a list of local treatment options for referral. Supportive dialogue is a technique that health professionals can use for deeper inquiry. It allows a woman to expand her life circumstances and provides the health practitioner an opportunity to provide education and correct misinformation. Here are some examples of questions that could be helpful. At least at first contact, it's advised to assume alcohol use by all women. Don't let appearance or status fool you into thinking that a woman does not have problem drinking or that she knows the facts about FASD. When engaging in supportive dialogue, it's important to normalize the inquiry, telling the patient that you ask all pregnant women the same questions because it's important to their health and to the health of their baby. It's important to be non-judgmental. Ask open-ended questions and phrase the questions in the past tense to avoid triggers associated with the stigma of alcohol use during pregnancy. If a woman has a known alcohol abuse history or is strongly suspected, it's okay to ask direct questions. Have you ever had a drinking problem? When was your last drink? In order to obtain accurate information about the amounts, it's advised to suggest high levels of alcohol consumption. For example, if a woman discloses that she drinks most weekends with her friends, she may be reluctant to specify an amount due to fear of judgment. If you ask for specific amounts, for example, you could ask, during these occasions, would it be 3 to 4 drinks or 8 to 10 drinks? This sort of inquiry has been found to yield more accurate reporting. So let's just review some of the things that we learned. Three-quarters of all Canadian women report past year drinking. 50% of pregnancies are unplanned. Pregnancy is not usually discovered until the 6th week of gestation. When exposure to alcohol prenatally can impact the fetus as early as week 3. We've also learned that the demographic at growing risk for having a child who's alcohol exposed or has FASD is Caucasian, over 30, has a post-secondary education, is single, and earns about $50,000 a year. So knowing what we know about alcohol thresholds, the prevalence of drinking, and the timing of possible damage relative to when women usually find out they are pregnant, we know now that there's a window of opportunity for unintentional harm to come to the fetus. It's very likely that FASD is more prevalent than currently measured and likely underdiagnosed in some demographics more than others. For example, the white middle-class woman. So we also know that early diagnosis of FASD is shown to protect the child with better child outcomes and fewer secondary disabilities. We know that confirmation of prenatal alcohol exposure is essential for FASD assessment and diagnosis. We also know that confirming prenatal alcohol exposure in the absence of maternal disclosure is a barrier to FASD diagnosis due to a lack of documentation in medical and other records. The goal of this presentation is the hope for a future state where there is better collection, documentation, and access to information about a woman's alcohol use during pregnancy. In this future state, we would have better prevention, and we would be able to offer help to the woman earlier in pregnancy to reduce harm or to help her stop drinking altogether. From a diagnostic perspective, access to information about a woman's alcohol use during pregnancy will facilitate diagnosis for both children and adults who are impacted by exposure to alcohol prenatally and open the door to support and intervention. That's the end of our presentation. Thank you very much to Kathy once again and to Bourne for having us come and speak today.
Oh, thank you so much, Kelly. That was great. I learned a lot there. And the big takeaway for me is to ask, document in the patient record, and document in the BIS. So there was a couple of questions, so I just encourage everybody, if you have any questions, please type them into the chat box. You can access it on the bottom left-hand corner of your screen. And while the presentation was going on, there was a couple of questions. One, just clarifying where you can get the information for your hospital on alcohol exposure in pregnancy. So just to clarify, you need to have been given access to the clinical reports by your hospital's local admin. So it's a role granted by your own hospital site. So if you don't have that access and you feel you need it, the one to talk to is the local admin at your hospital to give you that access. And then if you do have that access, you want to be in reporting on the clinical reports tab, and then you go to the key indicator maternal summary, where alcohol exposure in pregnancy is one of the reports that you can access. Many, many reports to choose from, but that one is there as a standalone kind of point and shoot standard report, really easy to get at. We had another question about the slide deck being available, and just want to let you know that the slides, as well as this recorded webinar, will be available within a week on the Born Ontario website, which is www.bornontario.ca, where we keep all of our training materials, and this one will certainly be added. So I just encourage you, if you have any questions for Kelly while we have our expert here, is to get them into your the chat box there, and we'll be happy to ask. So we have one from Christina, who I know is a CMNRP consultant. She says, thank you for a great presentation. There's such a discrepancy between the self-reported rates and the actual consumption of alcohol during pregnancy. Great suggestions for healthcare providers to have an open and non-judgmental discussion. Totally agree, and I'm sure Kelly agrees with that too. Do you have any comment on that one, Kelly?
I think FASD only came on the scene in the 70s. So the awareness of the damage that alcohol can cause to the developing fetus is still shockingly poor, even within the medical or allied health community. So there are a lot of discrepancies. I think there's a lot of power in knowledge and in public education, and the more that people know, men and women, about the dangers of alcohol, hopefully regardless of what we can capture, the rates of drinking during pregnancy will reduce.
And I found it really interesting when you said, you know, the majority of women are asked about smoking and then less so about their alcohol consumption.
Yeah, it is quite shocking, since neither smoking or other drug use cause the type of damage we see in FASD. Mm-hmm. And it is just all about education. And just sort of a little story that I have that's a little bit interesting, and I told you this one yesterday. My son is a second-year family practice resident, and he was home recently for a few days. And I was preparing another presentation about FASD, and I asked him what his knowledge of FASD and alcohol thresholds were, and he did not have a good knowledge. Certainly he knew about FASD very generally. He knew that you shouldn't drink, but his understanding was that, you know, some alcohol during pregnancy was okay, when in fact, you know, we do have these thresholds, but they're not in hard and fast. It's not hard and fast scientific data. And even when they publish the thresholds, you know, there's a disclaimer in there that no known amount of alcohol is safe.
Yeah, very interesting. So there's another question here that says, thank you for the presentation, Andrew. How is the data for alcohol exposure in pregnancy collected in the BIS? So data collection in general in the BIS comes in a variety of ways. Often it's manual entry by the nurses, direct nurse entry. It can be batch upload if that hospital is using an EMR. Less often by the use of like a worksheet that's filled in by the nurses and then given to a unit clerk that's added manually, or a medical records person. So what's really important about documenting that exposure in the BIS is that the nurses or whoever's entering the data can pull that data from the patient's chart, which they should be doing. And so if that primary care provider has not documented that conversation about alcohol exposure and what her answer was, that may be unknown data. The other thing the nurses can do, if it's direct nurse entry and the labor and delivery nurses are entering the data, is to ask a question to the mother herself and then document it in the patient's chart and document in the BIS. What's interesting to me is that we had a great rounds last year at this time, actually last November, on woman abuse and how that data was collected to be entered into the BIS. And a lot of hospitals on their admission sheet had added domestic violence questions to be asked at the time of admission to labor and delivery. So it was right there. It was part of a tick sheet. It could be asked, number one asked, and number one recorded really easily, and that way entered into the Born Information System accurately. What's interesting to me is the question for alcohol exposure is not on that checklist. So that's a good tip, I think, to the sites that are entering into Bourne, as all birthing hospitals do, is have a look at your admission documentation. Is this something that we can add there, that the nurses can ask at the time that she presents to the hospital, including labor? It's not a bad time to ask. So anyway, interesting to me that the woman abuse question is there, alcohol is not, and maybe that's something that we need to look at. I hope that answered your question. There's another question here. What do you suggest we say to pregnant women who report drinking before they knew that they were pregnant? Is there any reassurance we can provide or evidence about what might be the result of this episode? That's one for you, Kelly.
I think that if a woman has disclosed that she drank before she was pregnant, I would just try to reassure her. Reassure and educate so that she doesn't continue her drinking, of course. But I think there's a lot of unintentional harm. The timing, it just doesn't work, right? Damage starts at week 3. We don't usually know we're pregnant until about week 6. Depending on our drinking patterns, and there's a really high risk group between 15 and 19 years of age that, and those young university and college students that may, participate in a lot of binge drinking on the weekends. It puts that fetus at risk of harm, there is no doubt. But the only thing that she can do at that point is to stop drinking. There's no benefit in heightening her anxiety. And I think she will probably go out and find out probably more about the impacts of drinking. I just don't think fear-mongering at that stage is beneficial. But just providing education so that she stops her drinking.
And then just a follow-up question to that, Kelly. What if the woman is concerned to the degree that she's considering termination?
Well, I think women have to know what their choices are, and certainly that's a very I've been asked this question before. Should we advise termination? Certainly, you educate the woman, and then she has choices, and she needs to educate herself about her choices. One of the things that happens to a very heavily exposed embryo or fetus is that it self-aborts. It may if a woman has very problematic drinking, she might miscarry. I have known some women who have engaged in significant drinking before they knew they were pregnant at month 3 or so, and do consider that option. So I think she just has to be aware of what her choices are, and those choices are very personal to her.
And I would think a big part of that conversation is an honest conversation about how much alcohol she is or had consumed, right?
And I think too, we have to realize that every alcohol-exposed baby is not necessarily going to have FASD. About 50% of children. So we assess 100% of the children we assess are alcohol exposed. Probably about 55% of those receive a diagnosis of FASD. So it could be that the child has been spared. So not every child that's been exposed to alcohol will have FASD. So that's another important thing to consider.
Thank you, Kelly. A follow-up to that again is typically what I've seen is not a woman who is drinking regularly, but, for example, attended a friend's wedding and had a few episodes of binge drinking in that week, but not regularly otherwise. Then they found they were pregnant and then were, of course, upset with that information.
So what I would recommend, once again, do the education, recommend abstinence, and really hope for the best. FASD in its milder forms, without facial features, is often not diagnosed until the child reaches school age, at which time they enter the school system. They can't conform. They may experience learning problems, may exhibit behavior problems. FASD affected individuals, because there's a spectrum, once again, I've met many FASD adults who have a lot of potential, who have fulfilling jobs, are in steady relationships, have children themselves. A few weeks ago, I met a wonderful young man who's a motivational speaker, quite funny. He does a really good job at describing FASD from a first-person perspective. People with FASD do have a lot of potential. So, it's a very personal choice. But to know that if their child at age 4 and age 5 is experiencing some problems, if you know you've used alcohol even early in the pregnancy at or above the threshold, and the threshold is quite low, 2 binge episodes. So you go to the pre-party for the wedding, and you go to the wedding, and you may have exceeded the thresholds for an entire pregnancy. So they need to be aware of that, and then seek interventions and supports for their children.
I think that's a good point, Kelly, to be aware of, what to look for as a child gets older. That's awesome. Thank you. And just a comment, really, from Christina at CMNRP. One of the key FASD prevention strategies is to have multiple conversations throughout the prenatal period. The common practice now is to ask at the first prenatal visit with no follow-up conversation. And I totally agree with that.
Yeah. Because really at the first contact, you're opening the door. And they may not be ready to disclose, or may not be ready to engage in a conversation. So ask early, ask often.
Awesome. There's no other questions in the chat box at the moment. We'll give it another minute, but we're getting close to the end of our time. I just wanted to let everyone know that our next scheduled Born Provincial Rounds is Thursday, January 21st from 12 to 1, the same time period. And the topic will be the development of the new Ontario perinatal record. Exciting topic. Presenters will be Dr. Anne Berenger and our own Dr. Anne Sprague. And stay tuned for an announcement of that provincial rounds in January. So no other questions in the chat box there. I really would like to thank you, Kelly and Erica, for a great, great presentation, and thank you for helping us to understand the effects of alcohol during pregnancy, reviewing the characteristics of FASD, how to ask the question, and the importance of getting valid alcohol exposure data. So ask and document and ask often. I learned a lot today. Thank you very, very much.
Well, thank you for having us.
Thank you.
Okay. So I guess we can give everybody 3 minutes back.